Osteoporosis is a thinning of the bone. And when the bone's thin, they become fragile and you're at risk for fractures. There are definite risks for osteoporosis. Some of them are in our control and some of them are out of our control. The ones that are not in our control are things like our sex. Females are more at risk for osteoporosis than men. Our age, as we get older, we can't help getting older and we hope we get older and older, but our bones get older and older with us and they are more likely to fracture then. Our family history of osteoporosis. If we have a mother who had an osteoporotic fracture, we are at much higher risk of having an osteoporotic fracture. Some of the diseases that we have might not be in our control, like celiac disease or diabetes or rheumatoid arthritis. They may put us at a higher risk for osteoporosis. But there are things that are in our control. We can exercise because exercise strengthens our risk. We can make sure that we're getting an adequate supply of vitamin D and calcium. We can make sure that we're getting an adequate supply of protein. Actually, protein is important for our bone building as well. And we can make sure that we don't smoke and that we don't have more than 2 drinks of alcohol a day. Osteoporosis is actually an asymptomatic disease. In other words, we don't know that we have osteoporosis. Some of my patients say, I can't have osteoporosis, I don't have any pain. Well, pain is not a sign of osteoporosis until you have a fracture. Once you have a fracture, then you know that you definitely have osteoporosis. And let me talk to you a little bit about osteoporotic fractures. Sometimes people say, I had a fracture, but I fell. I was on the ice and I fell. If you fall from a standing height and have a fracture, we call that a fragility fracture, and that is a sign of osteoporosis. In other words, young people may slip on ice and fall, but they don't get fractures. Very young kids might, but once your bones are settled, you don't get a fragility fracture. So once you've had a fragility fracture, any fracture from a standing height, or you have a bone density done, and a bone density will tell us whether you have osteoporosis or not. Basically, we suggest that women after the age of 65, and some men after the age of 70 or 80, and maybe some women who had premature menopause. In other words, they have lost their ovaries either by hysterectomy or their ovarian function because they had premature menopause, that they get a bone density study done. The bone density study is basically easy for the patient. You lay down on a table. There's a machine that comes over you. It doesn't touch you. It doesn't hurt at all. It's not scary. And from there, you can see what the bone density is, because dense bones are less likely to fracture than bones that are thinner. So once you have a bone density study, there are 3 things that we as physicians look at. One is your T-score, one is your Z-score, and the other is something called your FRAX score. Your T-score compares your bones to the bones of a healthy 20-year-old female, because most 20-year-old females, don't fracture their bones. So they look and they compare you. So if your T-score, and then the T-score goes from a 0 to a plus and a minus. If your T-score goes into the minus side, from 0 to minus 1.5 is called normal. From minus 1.5 to minus 2.5 is called osteoporosis. Okay? And if it's higher than minus 2.5, then the higher it is, the more risk you'll have of fractures. The Z-score compares you to somebody of your race and age. So a 70-year-old female is supposed to have a Z-score of 0. So she's compared to another 70-year-old female of the same age and race. If your Z-score is less, then you're worse than somebody that we would expect, a healthy person that we would expect you to be. Then there is something called a FRAX score, and that's very FRAX. And that's really important because the World Health Organization said, okay, so who should we be treating for osteoporosis? So you may have a normal bone density, but you may still be at risk for osteoporosis. And basically they look at your bone density, which you do when you do your DEXA scan. They look at your age, your sex, your race, your family history, whether you are an alcoholic, whether you have rheumatoid arthritis, whether you have been on steroids, and they put all of that into a formula, and from there they decide whether you should be treated for osteoporosis or not. So if your FRAX score is higher than 20%, your 10-year risk, they look at a 10-year risk. If your 10-year risk for osteoporosis is higher than 20% for a major osteoporotic fracture, or more than 3% for a hip fracture, then you should be treated. Once you've been diagnosed with osteoporosis, there are a couple of things. The first thing is that you yourself need to make sure that you're getting enough calcium in your diet, that you are getting enough vitamin D in your diet, that you're not underweight, and that you're exercising. But once you've got osteoporosis, you have to be careful about what exercises you're doing. So if you have osteoporosis, you shouldn't be doing any quick twisting motions, such as golfing would not be a good idea. You shouldn't be doing sit-ups because there you can fracture your vertebrae, your back. But you should be doing weight-bearing exercises. So many of my patients think that weight-bearing exercises are when you carry a whole lot of weight. But basically, weight-bearing exercises is actually where you are bearing your own weight, such as when you're walking or running or dancing. That would be a weight-bearing exercise. Swimming is excellent, but it's not a weight-bearing exercise. We also want you to do strengthening exercises because if you've got strong muscles and strong arms, you're less likely to fall. Osteoporosis is actually a pediatric disease with geriatric consequences. And what I mean by that is that when you are a child, you should be building up your bones as strongly as possible. And you continue to build up bones until you're about the age of 30. So it's really important, and we don't think about osteoporosis at that time, but it's really important that children exercise. We think that they should have at least an hour of exercise a day, and that's decreasing tremendously as children are watching more and more videos and sitting down more and more. But an hour a day, getting enough calcium and vitamin D in their diet is really, really important because you want to build up your bones as much as possible until the age of 30. After the age of 30, remember that your bones are a living organism. So you are building up bones and you're breaking down bones all of the time. That's what happens. And until you're 30, you are building bones more and more than you are breaking them down. After the age of 30, the breaking down process outweighs the building up process. And so the bigger the amount of bone mass that you have, the least likely it is that you're going to develop osteoporosis later on. Getting enough calcium in your diet is really important, and the right amount, not too much and not too little. Some people think that the more calcium that they take, the better it is. But you have to understand that calcium has to be taken together, or you need adequate amount of calcium and vitamin D. We'd prefer you to get calcium in your diet rather than getting it through supplements. Which foods have calcium? Dairy products have calcium. I tell my patients you get about 300 milligrams of calcium in a glass of milk, 300 in a cup of ice cream, 300 in a cup of yogurt, 300 in a fortified orange juice. You get calcium in sardines if you're eating the bones of the sardines or the bones of tuna fish, like in canned tuna fish. And if you can get an idea of how much you're having a day, and then supplementing it with calcium supplements if you need to. Now there are two types, there's calcium citrate and calcium carbonate. Calcium citrate is more expensive, but it's easier to digest and can be taken with or without food. And calcium carbonate can cause some constipation, but it's cheaper, but it has to be taken with food. Then there's vitamin D, and we don't know exactly how much vitamin D people should actually have. You can get vitamin D from the sun. If you live in Miami and you walk around with short sleeves and shorts on, and you're in the sun for 15 minutes a few times a week, you probably get enough vitamin D, but we're not suggesting that people do that. And so many people have to get it either in their food, and it's hard to get it in your food. You get it from fatty fish, such as salmon or mackerel, and you can get it from supplements. And I tell my patients to take 1,000 to 2,000 milligrams of vitamin D a day. There are many treatments right now. You can take them orally by mouth, and that you can take 1 pill a day, 1 pill a week, 1 pill a month even. That's one of the ways of doing it. You can get it by injections, and the injections can be given by yourself every day, or you can get an injection once every 6 months, or you can get an injection once a year. So it depends. And you need to speak to a physician who understands about the medications, because some of them are contraindicated in certain diseases. Some are better for bone building than others are. Some should be given to high-risk patients, to higher risk patients, and not to lower risk patients. And basically they should be followed by a physician. Also, some of the medications are very, very costly, thousands of dollars a month. So the choice depends on your disease, your physician's decision about your bone density, and the cost, and whether your formulary will cover it.